Welcome to everyone here. A warm welcome. We're in different time zones around the world, but it's so nice to have you joining us. For me, it's this morning, and for some of you, it's this afternoon. Others, it's going into the evening. Today, this session is about the role of IT in Taiwan's healthcare system, the national health insurance, and in the age of COVID. And let me see if I can now get my slides up. So here is, this lesson. I already said that session is about a lesson from Taiwan in meeting the COVID challenge and the role of IT in the health care system. Before I go into the main part of our program, I'd like to just have a few quick words about the Taiwan's health system and the COVID-19 situation in Taiwan, because it's different everywhere. First of all, Taiwan's, here's a profile of Taiwan. It's got close to 24 million people, but it's an aging society. We're going on about 15% over 65 and very low fertility. So it's a rapidly aging society. Now there's more 65-year-old and older people than there are younger people under 14. But you can see the GDP per capita in purchasing power parity is very high, close to 60,000. So it's the number 25th richest economy in the world. And then infant mortality, it's 4. It's a little bit above the OECD median. And life expectancy is 80 and a half. And then so just very quickly, what kind of healthcare system is it in Taiwan? It is a government-run social health insurance system. It's called the National Health Insurance. And the National Health Insurance Administration runs it through 6 offices throughout Taiwan. And it's a mandated system, so all citizens and legal residents must enroll, but then they have very, very low health spending. And they cover everybody, 99.9%, that's pretty impressive. And the way you pay doctors and hospitals and other providers is through fee-for-service and DRG for hospitals. But overall, above all that, you have a global budget, and that contains and controls overall spending. And then you would think that if it's a single-payer system, what about who delivers? Does the government or the private sector? In Taiwan's system, it's mostly a private delivery system. And it is very equitable because you get the same benefits for all. It's not at all like in the United States where the benefits you get from your insurance policy, if you're insured, differs from the policies that you hold. In Taiwan, there's one policy and everybody enjoys the same benefits. And it's affordable. The premiums are based on ability to pay. And then people can choose their doctors and hospitals. There's no gatekeeper. And most providers and 100% of hospitals contract with the government to deliver services. And then about 99% of the people pay their premium on time. It's a monthly premium. And here, you may also ask the question, if it's single payer, maybe, you might ration care. But no, in Taiwan, you have very high utilization. The number of visits is 12 visits per person per year to your doctors. But if you include your dental visits, your visits to your Chinese medicine doctors, it's even higher, 15 times. And this is very high compared to the OECD average of 6.3 times per person per year. And length of stay also, you can see it's almost twice that in the United States. Now, waiting time is a big issue. single-payer systems often is plagued with waiting times, long waiting times. And here I've put together this table for you. You can see Taiwan for cataract surgery, total knee replacement, total hip replacement. Taiwan's waiting time in terms of days is a fraction of the waiting days in many other countries like Australia, Canada, the Netherlands, New Zealand, UK, and England or Scotland. Just a fraction of the wait time. So if you ask people, they'll say, oh, wait time, it's not a problem. And benefits are very comprehensive. Inpatient, outpatient, drugs, dental, Chinese medicine, prenatal care, daycare for the mentally ill, etc. You do pay a co-payment, but it's very moderate, and there are ceilings, the maximum amount you pay per month, per year. And then after that, you stop paying. And then there are exemptions for people and for specific diseases. Say if you have cancer, for example, there are no copays. And this is worth noting. The Taiwan system has a very powerful IT system, and that makes it extremely efficient administratively. What Taiwan spends on an administrative cost is less than 1% of their total government health spending. And then, of course, the IT, having such a powerful IT system also allows them lots of applications and innovations, which our keynote speaker will talk about in a little bit. And what about satisfaction? People are very, very happy with the system. The red line shows satisfaction. And right now, year 2020, it's 90% of the Taiwan's public are happy with the system. So now I'll just quickly mention the COVID situation in Taiwan. Think about it as two phases. The phase one is from January 2020 to mid-May of 2021. That's phase one of COVID in Taiwan. And in that period, there's no evidence of community spread, and the vast majority of cases in Taiwan are imported, people coming in or Taiwanese returning home. And there are no lockdowns of schools or businesses, and then there's no large-scale population testing. And according to the government statistics, in that period, in the 16-month period, under 200,000 suspected COVID cases, but 99% of them were dismissed. And the total confirmed cases in that 16-month period, it was only a little bit over 1,000. And about 90% of them are imported. And death in that period is just 11. And then also in that period, the total number of Taiwanese vaccinated is 27,000. And so you can see here's a picture of New Year's 2020. And people are out celebrating, having a really good time. But then something happened. In May of this year, 2021, you can see that COVID, see this, what's in the red circle, that's the previous 16-month. It's very flat, very low number of cases, low fatality. But then come mid-May of this year, cases started to go up. And so there is some limited community spread. But you can see as you move to the right of the slide that situation is gradually slowing and it's coming under control. So now if we look at the big picture of COVID in Taiwan, the total cumulative confirmed cases is about 15,000 to date, and total number of deaths is 706. case fatality is higher than many other countries, 4.68, and I think and their number of vaccinated people is still quite low, less around 11% of the population. And but say take yesterday, I mentioned that things are calming down. They've had 27 domestic and 2 imported cases and 17 deaths. That was yesterday, July 6th. So how did Taiwan beat the COVID? There are a number of reasons. You know, they learned from the SARS crisis of 2003, so they are prepared. And they have national leadership at the top, and they have a national plan for COVID prevention and control. And Taiwan's public really cooperated with the government. And then IT and communication infrastructure, of which the IT system of Taiwan's healthcare system, the NHI, it was a critical part. These systems, the infrastructure, support government anti-COVID operations. And we'll hear our keynote speaker, Dr. Lee, speak about the NHI part of the IT in a little bit. So our keynote speaker, I'm very honored and very pleased to tell you that we have Dr. Bojang Lee. He is the Director General of Taiwan's National Health Insurance Administration. He's the man in charge of running the NHI system. And he's going to talk about how the IT system of national health insurance plays a role in fighting COVID-19, the case in Taiwan. And we have a very distinguished panel who will comment and discuss together. We have here, let me just go over to tell you a little bit first about, this is our program. We'll have the keynote and panel discussion, and hopefully we'll have time for audience Q&A. Dr. Lee has been the Director General since 2016, so it's 5 years. As the Director General, he has carried out a number of health insurance reforms, especially in digital development in Taiwan's national health insurance. And before becoming the head of the NHI administration, Dr. Lee was an academic clinician and researcher. He is a surgeon and a professor at National Cheng University Medical School. And he's involved in both clinical and research fields of organ transplantation for over 40 years. He was the chairman of Taiwan's Organ Donation and Transplantation Registration Center. And in the 5 years since he's been Director General, running the NHI, public satisfaction for the program increased from 81.7% in 2016 to 19 and 90.2% in 2020. And let me just briefly also introduce our distinguished panel. Professor Kathy Mihalopoulos, I probably pronounced it wrong, please correct me. She is the head and chair of Deakin Health Economics at Deakin University, one of the largest groups of academic health economists in Australia. Her major field of research interest is the economics of mental health and psychosocial care, with a special focus on economic evaluation. And she has over 160 publications and has been a named investigator on grants, tenders, and consultancies totaling over $60 million. And then we have Professor Yasuki Kobayashi. He a professor at the School of Public Health and Graduate School of Medicine at the University of Tokyo. He is a founding dean of the University of Tokyo School of Public Health, which was established in 2007. And he has rigorously worked in areas of health policy and public health in Japan for more than 30 years. And he has worked at various university hospitals in Japan. He's a clinician as well. So he's a true scholar and teacher and clinician all combined in one person. And then we have Professor Adrian Taus, who was the director for 25 years of the Office of Health Economics in the United Kingdom, stepping down at the end of 2018. And now he's a senior visiting fellow at the Health Economics Research Center at the University of Oxford. And he is also visiting professor at both London School of Economics and the University of York, where they have a really wonderful health economics department. And for 10 years, he served as a non-executive director of the Oxford University Hospitals NHS Trust, one of UK's largest hospital groups. And he was a former president of the International Society for Pharmacoeconomics and Outcomes Research, known, as many of you know, as ISPOR. We will go into the Director General's keynote address. So the floor is yours.
Thank you. PowerPoint. Okay, thank you, Tsung-Mei, and your excellent introduction. And I appreciate to have this opportunity to share Taiwan NHI experience with all the dedicated around the world. Yeah. Now, some of you are in the early morning, some are in the lunch, in the dinner time. Yeah, so it's good for me to share our experience. Actually, Tsung-Mei just taught that in Taiwan, yeah, the public are very satisfied to our national health insurance. However, the clinician, the medical providers, sometimes they are not very happy because they thought our single system just squeeze them a lot. Yeah. So today, I just want to share my personal observation with all of you. Actually, Taiwan is just a single payer system. On the other side, it's just, recently we met the COVID-19, and I just wrote an article talking about how in Taiwan the response to the COVID-19 and the BMJ opinion. The editor just give us this title. Yeah, I think it's very good for us. And the right side is that 2 years ago, I was just invited to Columbia University to share the Taiwan single payer system with the multiple payer system in the United States. Yeah. As Tsung-Mei just mentioned that in Taiwan, our national health insurance is just a single payer system. I think this is very unusual compared to Western countries. Yeah. For all of you, maybe you just have we call the many commercial insurance. Yeah. But in Taiwan, we just run by our government as a single payer system. And then the premium, yeah, we just collect it from the people and from the government and then for all employees. Yeah. So sometimes we have to communicate with them. How can we run the premium very well? This is sometimes a challenge for us. Yeah. And in Taiwan, almost around the 93% of the medical providers, they have the contract with our NHI. And almost all the people in Taiwan, they have, their health coverage by our national health insurance. Yeah. And I think one thing is very important, just we are talking about the world budget. Yeah. Each year, we know how much money we want to spend in our health insurance. Yeah. So in that way, we try to control, how can we spend in this money. Yeah. I think this is very important for us. And later, I just want to share what happened in Taiwan. Yeah. So 5 years ago, when I just in this job, yeah, I think we should have how to manage the national health insurance. We want to have big data to know where the money is going. Yeah, and we also wish our big data can be applied to, so we call the AI application. Yeah, and in the United States or in the Europe, we have the HIPAA or we have the GDPR. So privacy and security protection is also very important for us to run this big data. One thing is very important, as I mentioned that in Taiwan, we have the annual global budget. Yeah, and you can see in this one, yeah, we can see the red line, yeah, in the upper row. Yeah, red line, it means for Taiwan, for each medical performance, we just pay to the medical providers. We call the point. Also, for example, when you perform the appendectomy, we offer you 50,000 Taiwan dollars. Yeah, so it just means 15 Taiwan and thousand point in that way. So we can see we also have we call the claim point. Yeah. So the red line is a claim point, and the blue line is the budget that we had. Yeah. And finally, each year and each time we should if the performance is over then the budget we can offer. Yeah. Then we have to share and the over cost. Yeah. So in that way, for each medical performance, we can say for each point not equal to 1 point Taiwan dollar. So this is also not very comfortable for all the medical providers in Taiwan. Yeah. So I think one big data is very important. It means that for each year, where the money is going. Yeah. Generally, for medical providers, they run the medical performance. They wish to get a reasonable reward for them. Yeah. But in Taiwan, you can see if the error is up, means the drug fees we pay for us. Yeah. We wish for all the people in Taiwan, if they got sick, I wish they can get the best drug in Taiwan. Yeah. So for each innovative drug, it is always offered by our national health insurance. So we pay that money in the drug fee. And another thing is that we call the test or the examination. It means that the people, when they got sick, they go to the hospital. Maybe they have to draw the blood to test the renal function and the liver function, or they are just doing the CT scan or the MRI. I think so. We pay a lot of money in this part. However, in other part, we call the treatment or diagnosis. It means that some medical performance are done by the physician or the surgeon, and the devoted, we don't pay them a lot of money. Yeah. So this is always for us. We should know where we will have to do. Yeah. Generally, in the Western country, we know. They always say that for the budget we have to pay for the outpatient maybe around 40% is enough. But in Taiwan, yeah, we found the outpatient almost occupied around 70% of our budget. This is just very important for us because generally for many outpatient care, yeah, the patient disease maybe it's very mild, but for the inpatient, they are very serious, critical illness. Yeah, but we don't pay them enough reward. Yeah. So the inpatient expenditure is only around 30%. So I think this is very important for us how to make a adjustment. So as I just mentioned that the drug fee occupied a lot of expenditure. It means in Taiwan, yeah, we always the patient they don't have to pay a lot of money for the drug. Yeah, generally in Taiwan, maybe less than $6 for visit for the drug. Yeah, so for some people, yeah, they go to hospital, they get a lot of drug, and they don't take the drug very regularly. So you can see for some people, yeah, in their home when we offer them the home care, yeah, we found that they are many drug in their home, yeah, but they don't take it. Yeah. So in the future, we wish we can give the people some payment for the drug. Yeah. In that way, if they have to pay from their pocket, they know how to control it. Yeah. So today we just talking about the IT, and Taiwan is very amazing country. Yeah. We are small, but the IT system in Taiwan is good. Yeah. So we have a long history. We try to run with the NGI cloud. But these 4 years, yeah, we put it very aggressively. Yeah. So you can see from this PowerPoint, yeah, you can see many example, medication record, surgery record, and the examination record, yeah, and any service or examination result are all uploaded in the medical cloud. So in that way, many hospitals or many we say clinics, yeah, they can just share this medical information through the medical cloud. And we know maybe the drug, we just mentioned that maybe some people, they already get the drug. So they go to another hospital or go to another clinic. They don't have the opportunity to get more drug because the medical crowd always show how many drugs this patient already got. And another thing is that it's very important because if the patient, they want go to one hospital to do some CT scan or the MRI, they go to another hospital, we can just see this image through the medical crowd, so it is not necessary to redo it again. And this one is that how can we do it? I think the medical crowd system is very important. In Taiwan, in the past, we just use the ADSL to upload this information to the medical crowd. But I mean, the speed is very slow. But recently, we use the optical fiber. It's very fast. So you can see these several years, maybe in the medical center or regional hospital, they all have set the optical fiber to increase the speed of the upload speed, and even the pharmacy company, they also use this one. So you can see step by step. So in this structure, all the medical providers, they can use this IT system to make medical services. I think this is the most important for us to meet the COVID-19. And this one you can see in Taiwan. We found that in the past, many hospitals, they like to do the examination. Okay, but we have to pay money is one thing, and another thing is that the patient, they get more radiation dose, and we know the genetic change is very important for cancer occurring. So we try to reduce unnecessary radiation effect. So we just put this image upload. We can share it, very important. And you see, as we know, generally, I think many delegates, they are specialized in the finance. And we found that for some clinic or some hospital, they claim, the examination they have done. However, they don't upload the result, examination result. So in that way, we spend money, we pay money for them. But however, we don't know whether they done it or not, because this is just in the Western country. We always talking it is a medical fraud. And this is also, generally for the human being, they always try to they claim some money, but maybe they don't do it. So we know we have to make this management. And this is all the same, for some kind of examination, medical image. We also found many hospitals, they don't upload this image. But in that way, another hospital, they don't see the image, so maybe to do it again. This is one thing, and then this is not good for people. So I think this is also very important for us to manage this waste. So through this, COVID-19, I think in Taiwan, in the beginning, we are very successful. To control, the spread of the COVID-19. I think we in that time we just call it the TOCC. It means the travel history and the application and the contact and the cluster. How can we do it? As I mentioned, that we have the optical fiber and to have this kind of IT system to make all the medical providers, they can get the same information. So this information for each hospital or clinic, when they put the patient national health insurance card, and it's easy for them to see, oh, this patient is just travel from abroad, maybe from the different country, and another country is just very hotspot for the COVID-19 infection. So this is good for the medical provider. They can pay attention to the possibility whether this patient is not only the URI or the abdominal and we say the GI disturbance. Maybe it's possible for them to have the COVID-19 infection. Then they can do some PCR or faster screen test for this patient. So this is very important for us. And the occupation is also very important. Because for sometimes for air crew or for some people, they are working in the home care. It is very important whether if they have the possibility to get the COVID-19. And in that way, maybe it's easy to spread to some people. So we use this way to control the COVID-19. very well. Yeah. But today you can see, from our the delegate in our Taiwan, yeah, we still use our face mask because recently we just have an outbreak of our COVID-19, yeah. But our government asked us if we have more people who stay in the room, yeah, we still have to use the face mask, yeah. But I think we can control it well, yeah. So in that way, because now we know we can test the COVID-19 through the antigen test. We all through the viremia, yeah, through PCR. But in the beginning, yeah, it is not so popular in Taiwan, yeah. We always see whether this patient have some, so some we can call they have chest discomfort, yeah, and we just give the patient the chest X-ray. But we use this way to collect enough X-ray and to do some AI study, to see the possibility whether this kind of the chest X-ray image is just the COVID-19, yeah, and in Taiwan we did it very well, yeah, and in that way, so many doctors maybe they are not specialized in we call that the chestman, yeah, but if they upload the chest X-ray to Taiwan NHIA and we give him the feedback to them the possibility of the COVID-19 infection, yeah. And in the beginning, yeah, when in Taiwan, when we don't have enough face mask, so in that way, how can our government can be to let the people to buy the mask very even and very fair, yeah. We don't want them, to have many different long line just to waiting to buy the mask, yeah. So through our some pharmaceutical drugstore, yeah, and in that way we can buy our face mask and we use our HI card, yeah, and to to register when he want to get the face mask, yeah. So in that way, this is very important for Taiwan people. They can share the face mask very evenly, yeah. And recently we also know, this is just we call the COVID-19 passport, yeah. So in Taiwan, we have a very successful and we call the My Health Bank, yeah. So we put all the information over there. Generally, all the people for the past 3 years, they go to the hospital or go to the clinic, and the data or the drug they used are always in My Health Bank. So it's easy for him to discuss with his doctor, yeah, and he also know how to take care of himself, yeah. But recently, since we know the COVID-19 infection, when you have done this kind of the test or you have done this kind of vaccination, this is very important for the society to share this information. So we also put this information just in My Health Bank. So when you enter to some restaurant, maybe you just show him that you already have vaccination, yeah, and then in that way it means that you are safe, yeah, not so dangerous, yeah. So in Taiwan, yeah, I just mentioned that when we have the old people, it's easy for them to buy the face mask. In that way, it's easy for him to prevent some kind of the endemic infection, yeah. So we always call the influenza-like illness really decreased a lot in Taiwan. And just as Tsung-Mei mentioned that in Taiwan, we have many outpatient visits. But since this year, yeah, many people they have the face mask and they don't go to they don't go to the hospital very frequently. So the outpatient visits obviously decrease. Yeah. Yeah, I think the AI is very important for us to run the medical medical care. Yeah, but I still think the physicians kind hard and should them. We are not really replaced by the AI. I think to be the doctor, yeah, since I am the clinician for more than around 40 years, yeah. So I think doctors should be considerate to all the people and to listen to the patient. I think this is very important. This is a Taipei 101, yeah. Even today, we are all in the COVID-19 in the world, yeah. But in the future, if you have opportunity to visit Taiwan, you're welcome to see me and to go to our Taiwan NHIA, yeah. You're welcome. Thank you very much. Thank you.
Thank you. Thank you so much, Dr. Lee. It's very, very interesting talk. So let us now go to our panel. Kathy, why don't you take the lead?
So what I'm going to be talking about, so can you all hear me and see my slides?
Yes.
Yes, great. Okay. So I'll actually be talking about something a little bit different because so firstly though, thank you, May, for inviting me to be part of the panel today and to contribute something from the Australian perspective. And it was very interesting listening to Dr. Lee's presentation because we are a little bit different in Australia, even though we've probably not, experienced COVID in such a terrible way that many of the other, panelists may have in their own home countries. But my focus will be a little bit different in that I'll be talking about mental health because that's become a very substantive issue, certainly within the Australian context, and is likely to continue being a substantive issue. And also focus very briefly on not IT-enabled kind of, I suppose, technologies and ways that in Australia we've thought about potentially tackling some of the mental health consequences. So just very, very briefly, and I know I've only got, a small period of time, but COVID-19 in Australia, we, like Taiwan, have had very low infection rates and deaths. We've had small isolated cases of community transmission that have been largely linked to hotel quarantine breaches resulting from international travellers coming into the country. So our hotel quarantines are in the middle of our cities and it's easy for breaches to basically happen. Now, strategies to mitigate the risks do vary somewhat by state. So we are possibly a little bit different to Taiwan because we've got one overall federal government, the Commonwealth, and then public health is pretty much a state responsibility. So every state in Australia does things differently. Now, I'm in the state of Victoria, where we became quite famous last year for having a very long, protracted, quite severe lockdown when we had very small cases. And everyone was kind of scratching their heads internationally thinking, what's going on in Victoria? Why are they locking down so severely? And that is because I think the end goal for the government was very much elimination of community transmission. So they were really aiming for zero community transmission cases, and we got there. So what is now currently, in our news a lot is some of the other states are having, some localized breakouts, and they are in lockdown. So New South Wales and Sydney is in lockdown, and they were lamenting to us last year, and now we're lamenting to them that they are in lockdown, but not as long. But vaccination is a massive issue in Australia, and we're very slow in our vaccination rates. But we are an island nation, we're all by ourselves, and we've basically pretty much slammed shut our borders to most international travellers, and so I think that's part of our success. Now, this is just very briefly just to put us in context in terms of how Australia's doing in terms of COVID. So in this top graph here, and this is some kind of nifty statistics that we can all get from our World in Data website. Now, I will draw your attention to the x-axis here. So it's not, we're going from 0.1 to 1 case to 10 to 100. And right up the top, we've got, the United Kingdom and United States, who we know have had, some very substantive problems with community transmission of COVID. And down here, we've got sort of, Taiwan and Australia. And as we saw, Taiwan for a long time had almost no community transition. Australia did. We had a spike in August 2020. That was here in Victoria, and now we've come down and we're kind of, like plodding along. In terms of vaccination rates, so, internationally, we've done very well at controlling the pandemic, and our neighbour New Zealand is similar. In terms of vaccine rates, I think, as I said, there's a lot of issues that we've got in Australia with vaccines. There's vaccine hesitancy. There's kind of changing goalposts about, who should get which vaccine. So, initially AstraZeneca vaccine was going to be our main vaccine, but now that's kind of, that's changed where it's only our over 60s that are being recommended to get AstraZeneca and the under 60s to get Pfizer. And we basically don't have enough Pfizer to do that very, very quickly. So we've got some issues and, coupled with a little bit of vaccine hesitancy in the population as well. So moving on. Now, as May said in the beginning, my special area of interest is mental health economics. And I think the impacts of COVID-19 and mental health have been substantive. And in reality, I think here in Australia and probably everywhere else in the world, the mental health impacts are very much being considered secondary to infection control. So here last year, certainly the discussion was all about, reducing COVID infection rates, and everything else was kind of thought of secondarily with kind of, solutions offered to any other problems that may have arisen because of that. As a health economist, and I know myself and my team, we actually thought, is this the right decision-making framework that we might want to be considering? Do we want to be considering, impacts in terms of mental health, economy, lots of other things? People here in Australia, and I'm sure other places in the world, with other physical conditions actually didn't go to hospital or didn't seek healthcare. And so there were, externalities or subsequent things that were happening in the broader health system that were very important. And we wrote a piece about how we might start thinking about these things in the future. And I think certainly in the conference next week, there'll be a very interesting session chaired by Jane Hall and others that will be talking about economic evaluation in the context of a national, international pandemic like this. So I very much look forward to hearing what that panel says. So in terms of the actual impacts, it is a rapidly evolving evidence base, and it really requires longitudinal data, which is, currently being collected as we go. One recent study that was published here in Australia of a representative Australian sample that was interviewed every 2 weeks from March 2020, which is when really COVID became, really hit home here in Australia. And the high-level findings from the first 7 waves of that particular survey, and I should say the first 7 waves really take us into 2 or 3 months post-March, so not now. Mean levels of depression and anxiety were higher than what was estimated for our population in earlier surveys. Most adults did not experience changes in their mental health, and distress for most people was transient. But, and this is in this survey, but younger people experiencing recent adversities, and for example, here in Australia, we had a terrible bushfire season early on in 2020, and people with pre-existing mental health problems had very much worse trajectories and are considered vulnerable, and certainly populations that we really need to think about. But as I said, the evidence base is evolving. Other evidence has suggested that mental health impacts of COVID are sort of similar to what you might experience after a natural disaster or even after a war. And some estimates have, said that here in Victoria, 1/3 of Victorians experienced depression during our second long protracted lockdown. And the impacts could be delayed and long lasting. So I think, mental health is something that we all really need to take seriously. And I did really want to flag with you the impacts on young people. Now, this is here in Australia, but I think this is true elsewhere. And this is burden of disease as measured by disability adjusted life years across the lifespan. And purple is burden attributable to mental disorders. And as we can see, it's basically in young people where the burden of mental health is greatest relative to other disorders. And if we've got now this constellation of the pandemic, lockdowns and lots of different things happening, and we know that the mental health impacts seem to be worse in young people, I really think we need to take a very serious look at that and think about, how to manage that. Now, here in Australia, we had COVID happening, and we also had 2 major inquiries into mental health, all occurring at the same time. And one of them was a sort of a national inquiry called the Productivity Commission Inquiry into Mental Health. And here in my state in Victoria, we had our Royal Commission into Victoria's mental health system. And so the backdrop of the pandemic, some of the themes emerging from both reports for our mental health system was it was basically a system in crisis. We had demand outstripping supply. The right care at the right time was not being provided. We had this missing middle of care, which was people whose needs were too complex or severe for primary care, but not complex enough for specialist care, were really missing in action in terms of getting good, high quality, evidence-based care. There was poor system integration. Unlike Taiwan, we've got different states, different IT systems. They don't necessarily talk to each other. Very easy for people to fall through the cracks. Inequitable access, insufficient focus on prevention and early intervention, and lots more. Oh, my mouse has disappeared. Sorry, guys. Right, moving on. So in terms of the initial digital responses to the pandemic for mental health services, so our government very rapidly moved to telehealth provision of care. So there were a number of kind of initiatives that were rapidly rolled out to try and really mitigate the risks of mental health. One was via our national public Medicare system, which is kind of similar to what was described previously. And particularly, community-based psychologists and other mental health professions now could receive reimbursement for both face-to-face as well as telehealth services that could be delivered via, the computer or via telephone or whatever it might be. So clearly, people couldn't go and visit their mental health practitioner if they were in lockdown. So that was very rapidly rolled out. The other change that happened was that there was an increase in the number of publicly subsidised psychological therapy sessions per annum from 10 to 20. So under Medicare, which are basically community-based psychologists and other mental health professionals, the more, so that is our national system. We also have our state governments that also provide mental health care, and they are called kind of public mental health services, and it's more severe cases that tend to be treated in our, state-based services. They also rapidly, changed the way that they provided services to telehealth at the same time. But in terms of, the public sort of primary care system, the number of sessions increased from 10 to 20 sessions per annum. Now, the impact of this was that we had very, clearly service provider shortages. They already existed pre-COVID. It just became worse, and it just really led to unacceptable waiting times. We also had rapid rollout or extra funding and expansion of online interventions, both at Commonwealth and state levels. And we've got, there's some national examples and some state-based examples as well. And just to give you an example of something that was fairly new, these new services called Head to Health were funded. And they are both actual standalone services where you can go and, get help, but also there was quite a lot of investment into, this kind of online portal where you could go into this and find digital mental health resources from trusted service providers. And this has been, great because a lot of what is recommended to people are evidence-based kinds of interventions that are coming from kind of, trusted organisations. This is the equivalent kind of thing, but it's from our Headspace centres, and these are our youth mental health initiative here in Australia. We're quite well known about these, and this was, given extra support. We've got Headspace support and lots of other information nationally that our young people can go to and receive information. So what happened during COVID? Well, basically the impact, if we look at our Medicare funded services, if we go from March 2020 to sort of, January 2021, there was a kind of an increase in the actual number of mental health care services that were being accessed by our population. The green line up the top is Victoria, because we had it tougher than everyone else because of this lockdown, and this is borne out here. The black line is New South Wales, and the orange line is basically, the rest of the country. The bottom graph here is proportion of telehealth services. So we started off with a very, very low proportion using telehealth. We did have telehealth, but only for our rural and remote populations, but that was rolled out to our urban population, and most Australians live in the city. And as we can see, there was a rapid increase in telehealth services, certainly during the Victorian second lockdown, and that's come down a little bit because we're not in lockdown anymore, but the use of telehealth has kind of remained, even though you could go to still access your mental health professional face-to-face. In terms of demand for services, mental health services, look, this is a messy kind of table, but if we just focus on these two kind of, or maybe on the last column there, this is the change in demand of some of our online services. Lifeline, which is a suicide kind of, telephone counselling, a crisis kind of a hotline, Kids Helpline, and Beyond Blue. And Beyond Blue sort of offers online support as well. We can see that the change in demand for these services from 4 weeks compared to January 2019 to January 2021, there has been a substantive increase in, the amounts of calls and demand for services from these, three kind of online, interventions. To sort of finish up, mental health services in the era of COVID-19 in Australia, substantive increase in expenditure, both Commonwealth and state levels. Many of the services and interventions that have been expanded or rolled out have been evaluated in terms of their effectiveness and cost effectiveness, but many have not. And we are now seeing large investments being rolled out, but it's really important as health economists that we work out whether this investment is value for money. And investment, certainly here in Australia and elsewhere, in evaluation and routine data collection is urgently required, and we don't do that particularly well. The other problem is that rapid rollout of things means that prospective experimental designs are less feasible in terms of the evaluation of these sorts of things. So I think it's there where, routinely collected data where you can kind of launch, experiments within that kind of, routinely collected data really come into their own. It is difficult here because of systems that don't talk to each other, probably easier in Taiwan to do. So I might just leave it there. And thank you for your time. And I'll stop sharing.
Thank you very much, Kathy. That's really interesting. I mean, this may be the silver lining of COVID, that through it, that you have more greater attention and funding for mental health. So shall we now move to Japan? Professor Yasuki Kobayashi.
Yes.
Take it, please.
This is my turn. Hello, everyone. This is Kobayashi speaking from Tokyo. Before the presentation, I would like to express my thanks to Ms. Tsung-Mei Cheng for inviting me to this session today. My presentation consists of 5 parts: current situation, measures against COVID-19, effectiveness of the measures, use of information technology, and final remarks. So let me begin by talking about the current situation of COVID-19 in Japan. We have almost overcome the 4th wave, but we are now worrying about the next wave. And the cumulative number of confirmed cases so far is about 800,000. The total population in Japan is 125 million, and therefore the cumulative percentage of the people infected is about 0.6%. This slide shows the number of deaths from COVID-19. The number of infected people currently being treated or isolated at home is about 16,000. Among them, over 6,000 are hospitalized. Another 3,000 stay at designated hotel for isolation, and about 6,000 are isolated at home. To summarize the current situation in Japan, it can be said that COVID-19 epidemic is moderate. Let's move on to the countermeasures against COVID-19. These are the main measures against COVID-19, so-called soft lockdown, active surveillance, and evidence-based message. The implementation of each measures requires not only the government leadership, but also the collaboration of people or peer pressure among people. Peer pressure is important, but rather peculiar phenomena in Japan, and will be mentioned later. Under the state of emergency, the national and local governments impose various regulations on businesses and residents to suppress the epidemic. Most of them are request basis because of weak legal infrastructure in Japan, and therefore it is called soft lockdown. As concrete measures, stay home, closing bars, no audience event, staggered school, online lectures, and so on. So far, state of emergency or so-called soft lockdown order has been issued 3 times in epidemic areas such as Tokyo. Contact tracing is most powerful measures to break the chain of infections. 469 public health centers located nationwide play a major role in implementing contact tracing. Moreover, contact tracing requires the collaboration of people because it is necessary that each person should disclose their latest behavior and activities. This is an example of evidence-based message by the government. This message is derived from a simulation experiment using a high-performance computer. This message fits the Japanese sense because it shows concern for health of others in a good context. However, if we look at this phenomenon from another context, it may reflect peer pressure or silent pressure from others in Japanese society. Regarding the vaccine coverage, Japan lags behind other developed nations. Let's see the effectiveness of these measures. You can see the example of staggered class and plastic shield on the desk at an elementary school. Under the staggered class, half of the class came to school in the morning, and the other half came in the afternoon. As you know, almost everyone in Japan wears a mask. Let's see the use of information technology. Roughly speaking, there are 2 types of enterprises. One is a set of new systems by the government. The other is various challenges using existing systems, mostly from private sectors. HERSIS, Health Center Real-Time Information Sharing System on COVID-19, is a government-initiated digitization of patient reporting and follow-up systems. With this system, digital reporting of confirmed cases from doctors to public health centers and health checks for the cases isolated at home become much easier compared to the conventional fax or telephone-based systems. This is another system, GMIS, Gathering Medical Information System on COVID-19, allows us to grasp the operational status of hospitals, the stock of status of necessary devices and equipment, the information of patient transportation, and so on. With this system, it is possible to grasp the provision status of general ward and COVID-19 ward, or the shortage or sufficiency status of N95 masks, personal protective equipment, and etc. at each hospital. There is, however, rather a disappointing system, COCOA, COVID-19 contact confirming application for smartphones. This application was initially expected, but it was not widely used because it did not necessarily reflect within 1 meter for 15 minutes or over. The content of the message was ambiguous and bugs often occurred. Both in Android smartphone and iPhone, user rating were low. I skipped this slide because of the time constraint, and also skip this. This is a challenge of visualizing people's movement using smartphone GPS data. This slide shows daily liquidity population within 500 meters from Tokyo Station. During the first soft lockdown, daily liquidity population sharply decreased. However, during the second and third ones, the decrease of liquidity population was small. Using the smartphone GPS data, 2 economists reported that people's behavioral change based on the available information was more effective for stay home than the government order of state of emergency at the first wave of COVID-19 in Tokyo. In other words, people acted smart. For that purpose, prompt provision of correct information is indispensable. Finally, I would like to mention 3 remarks regarding Japanese situation. First, government message and people's personal preventive effort have worked so far against COVID-19 in Japan. Second, some of IT devices or systems have worked and others haven't, either intentionally or unintentionally. Third, regarding wider use of IT, there are big concerns about privacy in Japan because there is little way to remedy if personal information is leaked. That concludes my presentation. Thank you for your attention.
Thank you so much, Yasuki. That was really interesting. I
Welcome.
hope that the situation in Japan improves more and more in the coming days so that more people can attend the Olympic Games.
Thank you.
Yeah, so now let us move to Adrian. Adrian, please take us to the UK. What's happening there?
Thank you, May. So I don't have slides. I'm going to talk for 8 minutes about the situation in the UK. So in terms of COVID, the headlines, so we've had 5 million cases, 128,000 deaths. We're 18th in the world per capita list, but we're 7th in the absolute numbers of deaths that we've had as a result of COVID. So I'm going to focus in particular on issues relating to the electronic health record, EHR, in the National Health Service, the NHS. I want to recognize that there are other areas where data storage and management has been key, the supplying of ventilators, the targeting of personal protection equipment to those hospitals that need it, the running of the recovery trial by University of Oxford, which has found, amongst other things, the value of dexamethasone as a treatment for COVID-19. But in the context of EHRs, I want to talk about 1 failure and 2 successes, and then put those in the context of the EHR strategy for the NHS. So the general practitioner or the primary care doctor holds patients' EHR in England. Part of the EHR is managed nationally by NHS Digital, which is an agency that is accountable to Parliament. So that's the context. So I want to talk first about the 1 failure. And this is test and trace. Initially, testing was shambolic in England, as in many countries. The health minister promised large increases in testing, which he could not deliver. A new organisation was created at the end of May 2020 called NHS Test and Trace, with the objective of getting those with COVID-19 and their contacts to self-isolate. But it has struggled. A comparison found that compared to other countries which had used financial incentives and other practical support, including food provision and daily check-in calls from local officials, in England, those things had not happened. And in particular, there'd been a failure to engage with local government and that had the public health responsibility. A failure to increase testing in September of 2020 when schools went back was a major blow to managing the pandemic and contributed to the need for a second lockdown. Tracing is primarily not digital. It relies on telephone calls to COVID positive patients and emails, texts, and telephone calls to any contacts. This should all happen in 48 hours. And now, finally, NHS Test and Trace is able to contact 85% of contacts within 48 hours. But this has taken over a year to achieve. Testing capacity has increased substantially. It's now easy and quick to book and get a PCR test and to get results within 24 hours. But again, it's taken a long time to get here. Lateral flow tests, not PCR tests, are now the main testing route. By the end of May, that's the end of May 2021, 700 million lateral flow tests have been sent out. 100 million results, that's around 14-15%, had been booked into back into the system. So we're not clear if the tests were taken and not reported. So on to my first success, the vaccination program. As of 4th of July, 34 million people in the UK had received 2 doses of vaccine, 12 million 1 dose. That's out of a UK population over the age of 14 of 56 million people. A great success. It's been delivered primarily through primary care, but also hospital hubs and large vaccination centres in sports and conference centres. And the role of NHS Digital and the electronic health record has been important here in terms of identifying cohorts for vaccination in line with priorities and making sure that people are alerted. Once a person is vaccinated, the data then comes directly either to their GP system or via NHS Digital. And so the vaccination record should be updated in the GP records within 48 hours. And then people are contacted for timings for a second jab. If you want a vaccination certificate, then there's a national NHS app that links and gets this information from your GP record. Which brings me to my second big positive, which is linked to this NHS app, which was launched in 2019, which is service transformation. We've seen, notably in primary care, over the first few months of the pandemic, a shift to almost 100% virtual and telephone appointments, and also to video outpatient appointments in hospitals. The NHS app allows patients to organise repeat prescriptions, to book appointments in primary care, and to access their electronic health records, and as I mentioned, to obtain a vaccination record. It remains to be seen, however, if some of these service transformations will be kept. Will we go back to face-to-face appointments, or will we keep them to be digital? So the implications of this for the evolution of electronic health records in the UK. 2 points to make here. Firstly, we have a legacy of failed IT investment over the last 20 years. A report of the UK Parliament last year said it's 6 years since the NHS announced that they were going to be paperless. And none, I repeat, 0, of the vital components to make a digitally enabled care mainstream across the NHS are in place. In particular, there's been a lack of progress on the interoperability, and that is the sharing of data. What we have is an electronic health record that's built on successful primary care. Successful primary care IT that was built to enable primary care doctors to get paid, they're self-employed contractors working for the NHS, and to manage their prescribing, again within prescribing budgets. What we don't have and what we need are hospital systems to upgrade and link records to the primary care record. At the moment, the electronic health record is updated by the hospital sending letters to the primary care practice, which then inputs the data and updates the electronic health record. Second, final point I want to make is the availability of electronic health records for research. The government failed in 2013 to persuade people to allow their electronic health records to be used for planning health services and for research, concerns primarily about privacy. The government is now trying again post the pandemic. It's being told that anonymized electronic health data will be shared with planners, university researchers and scientists working in researching medicines, including pharmaceutical companies, but will not be sold or shared for commercial purposes. The plan was originally to start data linkage in June. It's now been postponed until September to give people more time to choose if they want to opt out. We already have a clinical practice research data link which links records for several million patients for research purposes. But if the whole of the NHS was digitally enabled with linkage in this way, then it would transform the research potential for using NHS data. So, final sentence. Overall, England is making progress in its use of electronic health records. COVID-19 has accelerated the process, but we still have a lot of work to do, notably in the hospital sector. Thank you.
Thank you. Thank you very much, Adrian. Very, very interesting. I think in the interest of time, why don't we just jump right over to discussion among the speaker and panelists. And you can ask each other questions and make comments. But I wonder if I can use chair's prerogative to ask the first question. Director Lee, are you there?
I'm sorry, Director Lee have some business meeting right now. So I be here represent, yeah.
Okay, okay.
You.
Okay, I guess the question really is, obviously Taiwan has been very, very successful with controlling COVID. You haven't had a catastrophe like many other countries had. And obviously IT tools has been a big help. And I wonder if you can name, say the one or two or even three most useful policies and IT tools that have helped you in tackling this big challenge.
Yeah, I think the Adrian's speech is very impressive, and we have a very similar app that is our National Health Insurance app, which is this app is kind of similar with your NHS app, and half of our population had downloaded this app, and 1/4 of our population even download their medical records in this app. So during this COVID-19 period, I think this app actually play a very important role, and people can get their COVID-19 screen test, and even the vaccination records can be found and easily checked in this app. I think that is very interesting. I want to share right now with you.
Thank you. I guess I was going to ask Director General Lee, what is the most valuable lessons that Taiwan, that he had learned, but now, maybe you can answer that question. What are the most valuable lessons for Taiwan in your very successful dealing with this challenge?
As you know, now is the second phase of our counter COVID-19 period. Since May, we have a big challenge because we have robust cases during this period. So we are actually entered into a lockdown phase. I think the most challenging thing, maybe Director Lee has a very real answer, but I can share something with you about the personal information data protection and the anti-COVID-19. When we want to do some public health countermeasures, and sometimes we have to share personal information with our public health agency. At that time, personal information protection, that is an issue. If we want to protect our personal information, and we also want to get more information to protect our populations and get the contact information or trace or case tracing, how can we get the balance between the interest of public and the interests of the personnel. I think that's a big challenge for us. And I think it's also a big challenge for all the countries at this moment.
Thank you. Panel, please ask questions, ask Taiwan questions, and you can ask each other questions. What is your takeaway from Dr. Lee's and from each other's presentations?
May I would say that privacy is a big issue. That it's certainly been a challenge in the UK, and it was interesting to hear it's been an issue in Japan and also in Taiwan. And it is this trade-off that one of the reasons that test and trace has not worked well in the UK is because of the restrictions on the use of data. And in particular, at one point, there was an app that was trialed that would collect people's information and hold it centrally. And people refused to sign up to it. So that for me is one of the challenges that we face in all of our societies.
Yes, that was true here in Australia, very much so. Privacy has been a massive issue. We had a similar app, the COVID Safe app, that was developed last year. Very few people signed up for it. And that's been an issue for us even going prior to COVID. You know, getting a national card has actually been impossible in Australia to do. And it is different to the UK and other countries, and it's really hamstrung us here. And we've been very lucky in that we haven't had to face the kind of cases that you have in the UK, largely because we're an island and we kept everybody out. And we can't even get our quarantining right because, all of our different levels of government quibble with each other about who's going to pay for what, Our biggest problem now, so I think finally, like in the UK, we've got contact tracing much better, which is why our lockdowns don't have to be as long now, because we're doing that much better and we are using much better IT systems. We've come into the 21st century like that, and I think we've all learned from each other. But our biggest problem, I suppose, maybe not uniquely to us, are the different levels of government and who pays for what and who has responsibility for what. And until we get our hotel quarantine right and vaccinated, and we look at your vaccination rates, Adrian, and we think the UK has done it. What is going on here? And it's very, very difficult. But I think privacy is a massive issue.
Yeah, the situation in Japan is similar. Privacy is very important. And then, for example, contact tracing is not digitalized. Depending on human power, staff of public health center ask the people regarding their behaviors or contact with cases, and some respond very correctly, the others didn't, and some of them didn't answer at all. That's the situation.
Apparently, I think Taiwan has been really, really successful with contact tracing and quarantine, because with the help of IT, that you have really carried that to the T. Would you say that was one very big contributing factor to your success in controlling the small number of cases, tiny?
Yeah, it's true. The IT system of National Health Insurance Administration play a very critical role during this pandemic control period. And actually, the IT system in National Health Insurance Agency, I think is among the best. Among the best of all the health authorities in Taiwan. Here there is a IT woman here. Maybe you can share something with Mr. Come here. I want to invite here. Come here.
Hello everyone, my name is Cheng, and I work IT department for a long time, and I got a chance to see Professor Jen when you visit to Taiwan one time, and this time I want to share is about IT system in Taiwan. All the things we just want to do, not just for one second. And we do a lot of hard work to do the infrastructure building system. And for example, we try to upgrade the bandwidth among the hospital and our system. And in that way, we got a better foundation to communication with each other. Another thing that we want to mention is we try to like Joyce just mentioned, we got a very powerful app in Taiwan that's for our system. And one more important thing is we try to include the mobile authentication system in our app in 2018. That's why we do lots of things together in advance. And when this time when we try to control the COVID-19 pandemic in Taiwan, all this IT foundation becomes a very useful tool because we can identify personal data online, and that would be a very good tool to purchase personal face mask in each time. So I think lots of things we can do, and we can do very thoroughly, and we try to do it better. That's why we still can use our technology to help the country to prevent the COVID-19 pandemic. That's what is my side story. Thank you.
Can I ask a question? Yeah.
Yes, please go ahead.
Yes, Tsung-Mei, thank you. Can I ask a question? Because the Andrea just
Adrian,
you just shared your experience of the NHS app, and you just said that the GP can use the NHS app to do some test and tracing. If that is the case, I think it is totally different. I think that is totally different from our story, because our app is for person to get his own or her own personal data, so they can reach out all the claim data in Taiwan. If I have this app, I can download it, all the information like the medical treatment information and test information, and also can do some they can, if hospitals want to share information, they can use the MediCloud. But this app is different. People can get their information by this app, and they can have the past 3 years information of his own or her own. But the app didn't have this function of to reach out to the practitioners or any hospitals. That is not an interactive app. So can you tell me more about your app?
So thank you. So in effect, it allows you to do what you're currently allowed to do via email access to your primary care, your general practitioner surgery. So you can access your health record, you can make appointments to see your primary care physician, and you can reorder prescriptions from your primary care clinicians. So in effect, it's focused. You can access your health record, and then you can access primary care services. So it doesn't allow you to access any hospital services. So the record, the electronic health record, is held in primary care. Hence, the mobile app gives you a route into those areas. So the challenge we have in the NHS in England is that we're not, at the moment, we're not able to link in the data collected and the services in the hospital sector into that system.
Mm-hmm. So your app is kind of the electronic health records mobile app?
Yes. So it does allow you to. It allows you to do two things. So one is, as you say in Taiwan, it allows you to access your record and see the treatments that you've had. But secondly, it does also allow you to book some services, but only from primary care.
Mm-hmm. So it's like a centralized data bank. All the medical...
No, because this is, so the issue there is that your link will be with your primary care doctor. So everything is held in primary care. So your app, your national app, has a link to your primary care doctor. So if you moved doctor, you would need to establish a new link to get access to the records.
I see. Whereas in Taiwan, you don't have that issue.
Yes, absolutely.
Because the patient is free to go to any doctor or any hospital, and that visit data, any medical record is uploaded to a central, say, pool. So it's and which any other doctor can access with permission of the patient, I think. Yes.
So it's very different.
Yeah. So now, we have been given permission by the IHEA organizers to go over time a little bit because we started a little late. Do our panelists and does the Taiwan NHI administration have some last comments? Maybe we take 30 seconds each, and then let's just go to a question from the audience. We have a few questions.
I'm fine, May.
Okay, so if not, so let's try to answer a couple of questions. One is, how has inpatient waiting times in Taiwan changed due to the COVID-19 pandemic? What steps has NHIA taken to ensure that times don't increase too much? Waiting time increases. How did COVID-19 impact on that? But you don't have much of a wait time problem to begin with, right?
Yes, we have very good accessibility of the medical care, even during the this period. But for the purpose of the hospitals can focusing on treating the COVID-19 patients. So we actually ask our hospitals to decrease their normal service, such as not necessary treatment or not so urgent medical care. Maybe they can postpone or they can change their treatment model. So recent days, we promote the telecare for our patients can get their medical care at home, and they don't need to go to the hospitals, and they can in order to decrease the risk of getting COVID-19. So I think indeed the waiting time can be longer than the normal period. But how long at this moment, I can tell you, I don't have the real number.
Yeah. But I think that the increased use of telemedicine, that is certainly one very positive change or transformation in the delivery of healthcare services around the globe. Here in the United States, you know, the telemedicine use is shot way up, and that really has helped a great deal. Okay, let's go to the next question. Why not use vaccines from mainland China? As we know, Taiwan has less than 10% of the population vaccinated so far.
I think it's about the regulations at this moment. We don't change the regulation and for this period. So I'm not the representative of CDC right now, so I think I can answer only this few.
Okay. Next question for Kathy. Although Australian response to COVID-19 has been universally lauded, would a federal centralized approach instead of a statewide approach have resulted in a lesser number of outbreaks and shorter lockdowns in Australia?
Gosh, I've got to be careful what I say here because there's lots of different thoughts and opinions about that. We have a long history of, you know, sort of a Commonwealth and state governments with varying levels of responsibility. It bodes for a complicated healthcare system, and it's boded for a complicated approach to COVID. So there's nothing new there, really. My personal opinion is that I think probably the federal government perhaps taking greater control of quarantine and ensuring that we had purpose-built quarantine facilities and not relying upon, you know, the Sofitel and the Marriott and hotels, or it wasn't only them, but you know what I mean, facilities that were not built for quarantine. And we know that we've got air transmission, room-to-room transmission. That's where some of the problems have been, you know, air conditioning systems that were not set up for this. You know, we should have had purpose-built proper quarantining facilities from the beginning. And certainly I think, you know, a level of government, probably the federal government should have stepped up there, hopefully, you know, and have done that. We've got one such facility in the Northern Territory, and there's not been one case of COVID that's escaped that facility. So, you know, that's kind of interesting. I think the states have kind of learned for each other. It could have been more efficient if it was done centrally because of this kind of, you know, different states grappling with their own systems and trying to reinvent wheels, and they all had their different little apps or whatever it was that they were doing. I think it, you know, some of this would have been done more efficiently. And as an economist, I kind of think about that possibly at a higher level of government. That's my opinion.
Thank you very much. Yeah, organizers, do we have permission for a couple more questions and then we stop?
Yes, you can keep going.
Absolutely. All right, thank you very much. Here we have a question from Laos. Is there any effort towards preventive measures and or planning for next waves of COVID-19 cases by leveraging big data and these digital technologies that have been presented so far, or those that may be in the pipeline? So who would like to go first? How about Taiwan? Next step, preparation for next step.
Okay. Now we are dealing with this step, but I think next step, there's still some innovative ideas we can use right now. Like using the AI technique, we collect the X-ray pictures and we developed a tool that can recognize the disease or the pictures of the COVID-19. And we insert this tool into our VPN, which is used by every hospitals or clinics. And they can use the tool to check the X-ray if that is kind of the COVID-19 patients. That would increase our ability of finding out the new cases. This is one of the example we used last year. In using AI technologies for big data, such as the TOCC, the Director Lee just mentioned in his speech, the TOCC, the travel history, occupation contact, and other information. And during these 2 months, we can easily put the suspected population into the TOCC information. That would help us to find out or get a warning signals when these people go to any institutions or anywhere in Taiwan. I think that is also an application of the big data. And others like the contact tracing. If one confirmed case was found in a clinic, and we can easily get all the patients list, like the 1 hour, during the 1 hour, which the confirmed cases showed in these clinics, because we have the claim data, and we can easily get these contact information of all the people who get into the clinic at that period. And others we are going to use is using our app. The app, just like what I mentioned earlier, the app, there are half of the Taiwanese have downloaded this app, and 1/4 of the population have downloaded all their medical records. So if we can if one person can get all the information of the PCR or screen test, like the recent days or the 3 days, and their vaccination records, and we can easily transform this information as a passport, digital passport, and showing in this app. So they can easily go to anywhere and showing their passport using their app. This is what we are trying to do, maybe for the next step.
Thank you. Australia, Japan, UK. What would you like to talk a little bit about what your countries are doing, getting ready for the next big one?
I think we're still dealing with this one, to be honest. I talked briefly about the vaccination passport, the arrangements that are being put in place now. And it may be that this will become a way of differentiating. So people who've had tests can demonstrate that they've had tests and or vaccinations will be able to do things that people who have not will not be able to. So we're starting to have a debate about whether that's acceptable or not. Is it discriminatory? If people choose not to have a vaccination, should we exclude them or should we accept them? So we're getting into other issues around people's rights and what it's acceptable to make people do or not do.
Thank you. Yasuki, Japan, Kathy, Australia, would you like to comment?
Yes, in Japan, the vaccine rollout together with multi-pronged measures against COVID-19 that we have done so far are the most important and reliable method to control the COVID-19, the next wave, control the next wave. And another concern is that how we should manage the Olympic and Paralympic Games for the coming 2 months. Yeah, that is a big issue in Japan.
Thank you. Kathy, pass?
Yep. So look, like others, I think for us now the priority is really all around vaccination and how to improve our very low vaccination rates. Some very clever thinking has to go on there because it is around vaccine supply, but it's also about vaccine hesitancy in this country. So we really need to think about our public health messaging to try and really get our population on board to vaccinate, because there is a lot of hesitancy along with some supply issues. And again, I just want to reiterate the mental health consequences of COVID. I just gave you a very brief snapshot, and I think this is not unique to Australia. I think this is around the world. And I think, you know, these problems will, you know, once we kind of, you know, look, mental health is a problem now, and it will continue to be a problem, particularly in our young people. And we really cannot underscore the importance of that, because I think, yes, we've got, you know, COVID and infection, but these are lifelong issues that can really hamstring people in their lives. So I think everybody globally, we really need to think about that and do something about it.
Yeah, thank you. Yeah, vaccination really is the answer. Here, that's what we're saying in the United States. I think we'll do this last question. People's Republic of China has been quite successful in tackling COVID-19 through extensive usage of extensive app-based data collection. Since we're discussing healthcare data privacy, I was wondering what the panelists feel about this.
Well, I mean, I would just repeat, personally, I feel we should have been much more aggressive in using people's personal data, but that's not a universal view, and a lot of people think that we have to respect privacy.
But how do you go about becoming more aggressive?
Well, it would require, this is the problem, it would have to require an act of parliament that would require the phone companies to hand over records, to transfer mobile information, etc., etc. And at the moment, you would not get that passed in parliament, full stop. So it's a political challenge, definitely.
Right. Any thoughts, Kathy? Yasuki?
Look, I think like a lot of things, right? Every culture, every society, every country is different in what in how they approach things and what they will tolerate and what will be acceptable to them. So I think there are some things that I think, you know, we can all learn from each other and do similarly, and then there are some things that we just don't, because at a societal level, you know, it just won't suit the society. And there's trade-offs of decisions that are made. There's always trade-offs. We know this. So I'm an economist. I know that there's a trade-off. And, you know, perhaps like Adrian in the UK, the trade-off for Australia might be a bit too high. And I think privacy does matter here. You know, I can't help but think, you know, anyone with a phone, honestly, you're getting tracked, you know, wherever you go. But there's something clearly to people different about having an iPhone and different, you know, with the government doing it. I don't quite understand it. I don't really care, but others feel much more passionately about it. So, you know, every society is kind of different in how they think about these things, and I don't think we can discount that.
Yeah, it's a very difficult question, but the way in the People's Republic in China is not realistic, at least in Japan. Persuasion is most important in our country. Yeah,
it's a universal concern, the concern for privacy. Any comment from Taiwan NHI administration?
Tsung-Mei, I because the vaccination is very important at the next step, and for the whole country to get their immunity, the herd immunity. So I want to share something about our recent innovative platform. So maybe Ziyu, you can say something about that.
Just from yesterday, we announced the people can register their willing to the type of the vaccination in Taiwan. And they just registered about these 2 days. And more than 118 million people want to come here to present their willingness to get a donation, to get a vaccination. And in that way, we got a chance to test in the very first part of the vaccination nationwide. And in tomorrow, and in Jinmen, Penghu, and some small island, they will start to register their appointment, and through our national vaccination platform. I think it's very good news for our people, and got a chance to, according to the priority of the vaccination plan, and we got a chance to do that. And another thing we want to say, and we got lots of vaccination donation from Japan, and we got more chance to allocate our resource to the right place. I think that's a very important step to our system and to our nations. Thank you.
Thank you. Thank you very much. I think we really must conclude this session. And thank you so much for the IHEA's indulgence, giving us this extra time. And I'd like to thank Dr. Lee and his substitutes from the National Health Insurance Administration. Thank you so much for being with us today. And I'd like to thank our panel for wonderful, wonderful presentations you all made. And thank the attendees to this session. Thank you for being with us today. And one viewer asked to know more about Taiwan's national health insurance. How would I share information? You can get my contact information from IHEA. So thank you all very, very much for a wonderful session, and be well.
Thank you, May.
Thank you.